the facility county district near your home and postulate how many of those children may have a congenital heart disease. But generally we pick very few, and those few that we pick, we don't manage to sort them out, or we pick them when it's very late. So this gap of diagnosing early so that we can intervene early and make their lives better or save them is what we need to address, and that's partly why you are being taught this. Please don't be the ones to go out and diagnose the children late or send them late. For this session, remember this is purely just an introduction and highlight into congenital heart diseases. We can't cover it fully, so we'll highlight and I'll show you how to go and read it. It's important that you understand the heart embryology as a basis for congenital heart disease. Then you understand physiology for you to know how, if something goes wrong, how will the child present, and therefore how do we correct that physiology or anatomy to look as normal as possible. Embryologically, remember that the heart is actually formed by week 8, and it's a 4-chambered heart with veins and arteries all normal, and it's pumping blood. So, and by 8 weeks, this is the first 2 weeks, where many of you will remember is where the atrium and the ventricles, septation, and AV valves are forming. This is about week 5. And honestly, very many of the mothers, or especially first-time mothers, don't know that they are pregnant within the okay. So if we proceed, the anatomy I will want you to remember is that the heart is made up of 4 chambers. It sits in the heart like this. From your anatomy, you remember the blood returned from the upper part of the body comes into the right atrium through the SVC, superior vena cava, and the part from the lower part of the body goes into the right atrium through the inferior vena cava. Then they get into the right atrium, which then pumps blood through flows into the right ventricle through the tricuspid valve into the right ventricle, and then from the right ventricle it's pumped through the pulmonary valve into the pulmonary arteries that then splits into 2, going to the left and to the right. From the lungs, it comes back into the left atrium through pulmonary valves, 2 from the left side and 2 from the right side that join the left atrium. From the left atrium, it goes through the mitral valve into the left ventricle, where it's then pumped through the aortic valve into the ascending aorta. From the ascending aorta, you get the coronary arteries that supply the heart. Then you get the brachiocephalic, which then goes one to the brain and one to the right subclavian, the left common carotid and the left subclavian artery, and then goes to the descending aorta. Usually the PDA or the duct in utero is somewhere here between the aorta and the pulmonary artery, so that it diverts blood instead of going to the lungs, because the lungs are not oxygenating, goes back to the descending aorta. So this is the anatomy I would want you to remember. As we proceed, therefore, I am sure you've had the various classes of heart diseases, that they are there. I will summarize it that usually we have the ones that do not have cyanosis and the ones that have cyanosis. So when we go to the ones that do not have cyanosis, the problem might be that there will be excessive volume load in the heart. Usually this is because of left to right shunts. When I say left to right, it means from the left atrial or left ventricle or the systemic circulation, which is through the aorta, back into the pulmonary circulation, which we call the right circulation. So into the right atrium or into the right ventricle or into the pulmonary artery. Things that can cause that is usually atrial septal defect, ventricular septal defect, or AV canal defects, or a patent ductus arteriosus. That's one way of causing problems for volume without cyanosis. The other cause is causing pressure load on the heart. This means purely because of obstruction to ventricular outflow, either from the right side through the pulmonary valve stenosis, or on the left side when the aortic valve is stenosed or there is coarctation of the aorta. And then those that cause cyanosis, one of you has still switched on their video, kindly switch off for the rest of us to help us out. Thank you. So the ones that have cyanosis, you have increased pulmonary flow, but there is no oxygenation. So the blood is still deoxygenated. So for example, no oxygenation of the blood that comes to the body, or there's mixing. So for example, when you have transposition of great vessels, TPA, or you have a single ventricle, when the ventricular septum does not form and you end up with one ventricle, or something goes wrong and only one ventricle develops. Or you have truncus arteriosus, so that you only have one ventricle one trunk getting out of both ventricles, and the blood mixes in the trunk that is supplying the lungs and the rest of the body. Or when you have total anomalous pulmonary venous return without obstruction, so that blood comes from the lungs, instead of going to the left atrium, it goes to the right atrium, then finds its way to the left side system. That causes mixing. This is when you have increased pulmonary flow or no more flow. Sometimes you have reduced pulmonary flow and therefore with cyanosis. So for example, in tetralogy of Fallot, pulmonary atresia, you have reduced blood flow to the lungs because the outflow into the lungs is reduced, and therefore blood finds its way into the left side without going through the lungs. Or you have tricuspid atresia, and from the right atrium, instead of blood flowing to the right ventricle, it finds its way into the left side, mostly from the PFO or through atrial septal defect. Sometimes you have total anomalous pulmonary venous return with obstruction, so that reduces also blood flow to the lungs. So in summary, this is what congenital heart disease is. This slide alone, then you will go and read what is involved in each of these. How do the children present? What do I look for when I'm examining? What will I need to do to confirm this diagnosis? And what is the treatment options available? Just this slide is all you need to remember everything. But we'll try and go through each of them. So the pathophysiology when you have left to right shunts is that you have oxygenated blood that recirculates in the lung, and some goes to the rest of the body. So you have more blood flow in the lungs than the rest of the body. When you have right to left shunts, you have desaturated blood that bypasses the lungs, or it goes to the body without necessarily going to the lungs, or there's mixing. In transposition, you have parallel circulations. We'll talk a little about this later. With obstruction, you have increased workload on the heart, and therefore it needs to hypertrophy or get tired by excessive work. This is basically all the pathophysiology of what happens to lead to heart failure in all the congenital heart diseases mostly. How do we make a diagnosis? I would still remind you, please remember the embryology, what is developing when, how it develops. It would be good for you to go back and reread it. Then remember the anatomy of what the normal heart looks like and how it functions. So that when you have all this and you are taking a history, you will be remembering what you need. Can you hear me now?
I can hear you.
Thank you. Then once you know that, what do you look for when you're examining? Once you've examined, how do you confirm? Is the radiological investigations. We ask you to do chest X-ray. What do you see in chest X-ray for each of these things? For example, in tetralogy of Fallot, you've been told boot-shaped heart. In left to right shunts, so you'll have increased blood flow to the lungs. Or if you have some of them that will lead to enlarged heart, you'll have a big heart. So cardiothoracic ratio is increased. On ECG, what will you expect to see? So I want you to go and read If you have right side enlargement, what are the factors that you will see on ECG? You have left ventricular enlargement, what do you see? So then you have a chest X-ray that has a cardiomegaly, and you have an ECG, for example, that shows you this right ventricular enlargement with cyanosis. Then you start thinking, what would give me cyanosis that causes right ventricle enlargement? For example, the tragedy of Farlow or critical pulmonary stenosis. Alternatively, if you have left ventricular enlargement with a cardiomegaly and no cyanosis, then you start looking at what would give me this. Then you start considering things like a VSD or a PDA. So that's how you look at it. Or pulmonary coarctation or aortic valve stenosis. Before you do echo, because echoes will not be available everywhere. Then the echo is what you will send for us to do a diagnostic investigations, just like an ultrasound, but looks like at the heart only. Occasionally, we will ask for CT scan or MRI. Sometimes we do cardiac catheterizations for diagnosis, but also for treatment. Laboratory tests depend on what you see, and usually we reserve this for infective endocarditis. Sorry, or when you have cyanosis and we want to see whether there are any complications. So please remember your history depends on the type of congenital heart disease and severity for you to make a diagnosis. Focus with each disease in mind. When we have delayed diagnosis, it causes problems with outcomes and what is possible to do. For example, if it's a VSD with delayed diagnosis, the child might have complications of pulmonary hypertension, and we say we are not able to do anything. So the earlier we diagnose, the less morbidity they have, the better the chances of survival. When there's cyanosis, it's easy to raise suspicion. Usually those ones you send to us very quickly. But in the absence of cyanosis or no mama, we have delayed diagnosis. So that is the emphasis I want to place out in this lecture. Some of the signs and symptoms could be from any organ. Mostly it's respiratory system, which we did this a few weeks ago. Chest pain, cough, difficulties in breathing, or breathlessness. Generalized signs, edema, easy fatigability, sweating, failure to thrive from GIT or poor feeding. CNS, they might have syncope, dizziness, fainting attacks. And generalized things, usually this is for other diseases, joint pains or claudication, myalgia, skin rashes. So please focus, evaluate, and narrow down to the system affected and what else could be the cause. Don't always assume that cough is respiratory. It could be other things, and have the pathophysiologic explanation in mind. I have asked a few of you to go look at classification of heart failure. I believe Professor Joey will teach you this as well. So in infants, we use very small things, whether they have symptoms or no, respiratory rate, and ability to feed, and how they are growing. And then the same thing with now failure to thrive coming in, and then the signs of respiratory distress. So please remember this for those who I asked for my ward. The medical treatment of heart failure in these children will depend on the cause, so you manage the underlying cause. Professor Joey will tell you about preload reduction. That's mostly we use diuretics. Which we use inotropes, and then afterload reduction. So those we will cover. So even in heart failure from congenital heart diseases, the principles of management are the same. So let's go to the acyanotic lesions. The ones without cyanosis, we start with those that cause from volume overload, which is left to right shunts. We go the easiest, the most common is an ASD, atrial septal defect, which means failure of the atrial septum to separate left and right, and you have incomplete closure of the interatrial septum. There are different ways of classifying these septal defects. But in essence, it's the same thing, that there's a gap between the left and right atrium through the septation gap. So what will happen is that you have blood flowing from the left atrium to the right atrium, and then into the right ventricle, into the lungs, back to the left atrium, and again to the right atrium. So in essence, you have blood flowing a lot in the right atrium, right ventricle, and the lungs without necessarily going to the rest of the body. The amount of blood flowing through the ASD is not dependent on the pressure differences between left and right atrium, but really on how the right ventricle accepts the blood, if I may use that one. I will leave it to you more. Compliance is the medical term we use. So if it's more compliant, more blood will flow. If the ASD is large, more blood flow will flow. If the ASD is small, a little blood flow. And this will cause right side enlargement with increased blood flow to the lungs. The murmur is not caused by blood flow through the ASD, but because of the increased amount of blood flowing through either the tricuspid valve or the pulmonary valve when the annulus is constant is what will give you the murmur. So they have talked about left to right shunting at the atrial level. Shunt depends on the size of defect and compliance of the right ventricle. The volume overload will be on the right atrium, right ventricle, and pulmonary arteries. Occasionally, they may develop tricuspid regurgitation and pulmonary regurgitation because it's being dilated, and therefore the closure is not adequate. Usually, there are no symptoms in young people, and as they grow older, they start developing more and more symptoms, especially with small ASDs. The only thing that you might have is recurrent chest infections. For larger ASDs, the moderate to large ASD will have slightly more left-right shunts, so they are the ones who might end up with volume overload, with right atrium and ventricle enlargement. Occasionally, you might have arrhythmias. A few of them will end up in heart failure as they grow older. Because of the increased pulmonary blood flow, there's remodeling in the lungs, then you end up with pulmonary hypertension. If there are clots, like we sometimes have DVT in the lower limbs, these patients may present with paradoxical emboli on the left side to the brain. As they grow older, the pressure and volume on the right side causes a widely split second heart sound. Second heart sound was a closure of the pulmonary and aortic valves. So because of the increased blood flow on the right side, it takes slightly longer for the pulmonary valve to close compared to the aortic valve. So you split the second heart sound. You might have a systolic ejection murmur at the left upper sternal border that radiates to the lungs because of the the flow through the pulmonary valve. Sometimes there's a soft diastolic murmur at the left lower sternal border, which corresponds to the tricuspid valve area. It's because of increased blood flow through the tricuspid valve. You may have a precordial bulge and right ventricular heave because of that volume, or prolonged PR interval and incomplete right bundle branch block. That's what I've written as IRBB. As they grow older, with increased volume and remodeling, pulmonary hypertension, and we've talked about risk of pulmonary paradoxical emboli. The history is dependent on the size, and generally they get more symptoms as they grow older. Examination, those are the clinical features we've discussed before. Chest X-ray will have increased pulmonary vascular markings. The right atrial border may be enlarged. ECG, you will have right ventricular enlargement. You might have right atrial enlargement. You might have the incomplete right bundle branch block. And then on echo, of course, you will see the SD. How do we treat? If they're in heart failure, manage the heart failure. The SD itself can be closed in cath lab. or surgical closure. So cath lab means we put something that looks like this device that is like two umbrellas facing each other so that the ASD septum will lie in between and these two things come and oppose against the atrial septum, then they will close the ASD. We thin it out and make it thin and long through tubes and then position it in cath lab without necessarily opening the chest through the femoral vessels. So that's an ASD. A VSD is more like an ASD, only that the hole is at the ventricular septum between the two ventricles. And because usually the left ventricle pressure is higher than the right ventricular pressure, the blood flow will be from the left ventricle through the ASD into the right ventricle and then to the lungs. So you still see there's increased flow into the lungs, although it is at the ventricular level. And the pressure differences will be high. And the physiology is also just determined by the size of the VSD. Small to medium-sized defects are pressure limiting or what we call restrictive. They are the ones that will make the most noise, as in terms of murmurs. The louder the murmur, the more likely that the VSD is small. Large defects provide no resistance to flow between the ventricles, therefore they are non-restrictive, and the blood flow might be extremely large into the pulmonary side, and this child will present more symptomatically with respiratory distress. So the VSDs, if they are large, the flow will be determined by how high the pulmonary pressures are and the systemic vascular blends. If the pulmonary vascular resistance is low, then you have lots of blood flow and hence more symptomatology, especially respiratory. But if the pulmonary vascular resistance is high, then it limits blood flow to the lungs and children are less symptomatic. But they are actually clinically worse to us because their pulmonary pressures are high, and these are the ones who may end up with Eisenmenger syndrome and inoperable. In all children with VSDs, there's increased blood flow to the lungs. There's remodeling of the pulmonary vasculature with time. If nothing happens, the pulmonary pressures become so high that then they end up with high pulmonary vascular resistance and eventually Eisenmenger. So these are some of the children who will be told they have a VSD. They are very symptomatic, but as they grow older, they become less symptomatic. That is worrisome because it means the pulmonary pressures have increased and there's less flow, hence less symptomatology. And that should worry you as a doctor. Clinically, if they are small neonates, 2 to 3 weeks, most of the time what you just see is tachypnea and tachycardia. Mottled, skilled, cold periphery, which are signs of heart failure. Much later is when you will end up with hepatomegaly and other signs and symptoms. Unfortunately, most of these children will be treated as sepsis because of the tachypnea and tachycardia with mottled skin when it's essentially heart failure. It is okay to treat them as neonatal sepsis because that's what we've told you in ETAT. But as doctors, think outside the box and start thinking, what else? Professor Musoka, the late, may God rest us all in peace, they used to ask us all the time, what else? As a doctor, you must always ask yourself, what else? Especially if the treatment you're giving is not working. It means there's something else that we have not picked or we are not doing rightly. Think twice. As they grow older, they get more clinical signs of heart failure, sweating during feeding or difficulties in feeding. They are not gaining weight, and they're the ones who will come with recurrent chest pains or chest infection, Sometimes the VSDs close if they are small and especially the muscular component, but some of them will not close. So they will end up with increased blood flow into the lungs, but it comes to the left atrium, then left ventricle, and during systole is when it moves through the VSD into the lungs. So blood essentially stays in the lungs, left atrium, and left ventricle. So it's a left atrium and left ventricle that will get enlarged, and sometimes the pulmonary arteries. Then the signs and symptoms of heart failure, pulmonary hypertension with time. As they grow older, this is what I told you, large VSD but balanced heart failure where they are less symptomatic. Outflow obstruction of the right ventricle sometimes occurs because of the muscles trying to enlarge and close the VSD. But in that process, they cause right ventricular outflow obstruction. Sometimes you have aortic insufficiency depending on where the VSD is, as it pulls the aortic valve leaflets downwards. Some of them might end up with infective endocarditis. What do you find? Well, when you examine, depends also on the size. You might find a thrill if the VSD is small and there's a murmur. Because of the left ventricular enlargement and or hypertrophy, you might have the apex beat displaced. It just means the heart is enlarged. The murmur will depend on the size of the VSD. It is usually on the left lower sternal border and it is systolic. Best heard in the direction of the jet. So the left ventricle is to the left and slightly posterior, while the right ventricle is right-sided and slightly anterior. So the jet will be from the left to the right and towards the front. Many times it will be at the left lower sternal border. And then the heart failure signs and symptoms. Usually, the VSD management is this supportive care, support the child to grow. If they're in heart failure, manage the heart failure. Volume overload will be reduced by diuretics, and then that's preload, and afterload you reduce by ACE inhibitors. Practice good oral hygiene, and sometimes small perimembranous and muscular defects may spontaneously close. If they don't close or there are other problems, for example, failure of medical management, the aortic valve insufficiency or regurgitation, there's increased volume load into the pulmonary system, or risk of pulmonary hypertension, we advise that you repair early. Occasionally, we put a PA band to reduce the amount of blood flowing to the lungs and allow the child to grow. If they have Eisenmenger, then we will not operate. How do we close them? Usually, if they are big, it is surgical closure. Open heart, close the VSD, close the heart, close the chest. If they are small and they are far away from the valves, we can do by catheterization, just the same way we do a device closure, just like an ASD. So essentially all you need to do is to cut off the blood flowing from the left side to the right side by putting a patch or a device after that. Thank you. If there are questions, please write them. We will answer at the end or in the words when you see me because of time. The lecture is very long and I don't want you to stay here for too long. AVSD is atrioventricular septal defect or atrioventricular canal defect. It essentially means where the atrial septum meets the ventricular septum, there's a defect, and between the AV valves. So that is what we mean by AV canal defect or AVSD. Right in the middle of the crux is where the defect is. There's an primum ASD, there's a VSD, and the AV valves, atrioventricular valves, also have issues with them. So the symptomatology will be a mix of both atrial septal defect and ventricular septal defect. These are the ones we really want to close before 6 months of age, if we can pick them early. If we delay, they generally tend to have very high pulmonary pressures, and then we say they're inoperable. They are associated with trisomy 21, which most people call Down syndrome. So the presentation, investigations, clinical signs will be almost the same as a mix of ASD and VSD. So that's why I'm not going to go more on it. Patent ductus arteriosus is when you have the ductus arteriosus, which is useful in utero, is supposed to close at birth. If it doesn't close off and becomes a ligamentum that is supposed to be, and there's blood flow, then you will end up with the blood flowing from the aorta into the pulmonary arteries, because the pulmonary artery pressure is lower than the aortic systemic blood pressure. And the magnitude of shunt will depend on the pressure gradient between the aorta and the pulmonary artery, and the size of the PDA, which will also determine the resistance within the PDA and the pulmonary resistance. You have increased pulmonary blood flow, and because of lower lung compliance, you have increased work of breathing, so they'll also present with signs and symptoms of respiratory distress, and therefore increased blood return from into the left atrium from the lungs. It will also present when you examine, just like the PSD, with left heart enlargement. In this one, because the pressure in the aorta is much higher than the pressure in the lungs at all times, in systole and in diastole. So in diastole, you have blood flowing from the aorta to the pulmonary artery through the PDA. The same way in systolic circulation, you have pressure flowing from the aorta into the pulmonary artery. So there will always be blood flowing, whether in systole or in diastole. So you end up with a murmur both in diastole and in systole. And we call this continuous murmur because it's in both diastole and in systole. So some people call it a machinery murmur because it will be running throughout like a machine. So the constitutional symptoms of a cyanotic congenital heart disease will be the same. Respiratory distress. This murmur will be continuous. It is best heard in the left upper sternal border, infraclavicular region. Doesn't change with position. Because there's a lot of runoff into the pulmonary artery. In systole, the systolic pressure will be high. But in diastole, a lot of blood flows back into the pulmonary artery. Therefore, the diastolic blood pressure becomes lower. So then you end up with a high systolic pressure and a very low diastolic pressure. And that creates a wide pulse pressure. They are also the ones who will end up with bounding pulses because of the volume. And you will go read other causes of bounding pulses or wide pulse pressure. So the other things they will present with heart failure, atrial fibrillation if the left atrium is enlarged so much, endocarditis. Many times we found it as an incidental findings, especially in small asymptomatic PDAs, many times when we don't auscultate properly. Diagnosis, history, examination, we've gone through the features. Chest X-ray will have increased pulmonary vascular markings. The pulmonary area will be full because the pulmonary arteries may be enlarged. The left You can hear me? Okay, good. So the left atrium and left ventricle enlarged, so you end up with cardiomegaly on chest X-ray. ECG will give you features of left atrial enlargement and left ventricular enlargement. The echo will show where the PDA is and the flow. For those who are interested in cardiology, come and see in echo room. If you stay there for 2-3 days, you will most likely see a PD and we'll demonstrate how it looks. Management in neonates, especially preterms. If you give paracetamol or brufen, it might close the PDA. But please don't close the PDA. We need it for survival. If they're in heart failure, manage the heart failure and support them nutritionally. Most times we'll close PDAs by catheterization. We put a plug inside and we stop any flow. For large PDAs or very small neonates where the PDA device will not go through the vessels, then we ask the surgeons to close it. Sometimes the PDA is our friend and we don't want to close it. This happens when you have duct-dependent lesions. For example, when you have complete right heart obstruction, so that there's no blood flow from the heart to the lungs, such as critical pulmonary stenosis, very severe tetralogy of Fallot, pulmonary atresia, or tricuspid atresia without a VSD. So the only way the lungs will get blood in that neonate is the PDA. These are the ones we don't want you to close the PDA. It's a duct-dependent lesion. Or when you have left heart obstruction and you need the PDA for systemic blood flow. So for example, in critical aortic stenosis, it is better to leave the PDA open so that the blood flows from the pulmonary artery into the aorta post the coarctation or aortic stenosis. Better off to have deoxygenated blood than no blood at all. So critical aortic stenosis, co-arc is coarctation of the aorta, HLHS is hypoplastic left heart syndrome, and IAA is interrupted aortic arch. Sometimes the aortic arch can be interrupted in some congenital anomalies, and you need the PDA to supply blood post the interruption. Or when you have transposition of the great arteries, it is better to leave the PDA open so that some blood flows and mixes between the systemic and the pulmonary circulation. Please remember this, don't close PDAs in neonates without knowing what other problems this child has. So that is what I will say for the acyanotic ones, or that cause volume overload. So if we go to pressure overload in simple terms, we have the coarctation of the aorta is the most common, where you have some narrowing in the aortic arch. And many times it's where the PDA attaches. It can be a discrete small narrowing, or it can be a long segment, or you can actually have complete interruption of the aorta and it's not continuous with the descending one. Most of them will be associated with a bicuspid aortic valve. Usually the aortic valve is trileaflet, but when it's bileaflet, we call it bicuspid aortic leaflet, and it's associated with coarctation. In simple ones, or not so severe, they will grow and not picked usually, and they will be picked as older children. When they are complex, they have many other associated problems, and they are picked early because the children will be so sick. They will present with dyspnea, poor feeding, diaphoresis, or they became pale. They have tachycardia, and the pulses post the coarctation will be poor. You might have a murmur, and there will be saturation differences before the coarctation and the post coarctation. So the duct, the PDA will supply blood the post-coarctation area, which is postductal. That's what we mean by postductal. So because the PDA will supply blood that is deoxygenated to the postductal side, therefore the saturation will be lower. But before the duct, before the coarctation, the blood will be from the left ventricle, which is well saturated. So that part will have good saturations, good pulses, but postductal or post-coarctation, the saturations will be lower and the pulses will be lower. So clinically, you can make a diagnosis of coarctation. The heart will have systolic dysfunction with poor cardiac output, and you have increased end diastolic pressure, leading to increased left atrial pressure and pulmonary respiratory distress. And they will end up with heart failure, with acidosis, shock, and renal failure because of poor blood flow to the kidneys. Upon ductal closure, this is when many of these symptoms will worsen because of the obstruction in descending aorta that develops rapidly before the heart has developed hypertrophy to pump past the coarctation and develop collaterals. If there are other associated problems, they will compound the problem. For these children, we will advise you to keep the PDA open, stabilize, then we operate or open up the coarctation. In older children, many of them will be referred because of a murmur or high BP. They're the ones who will be said they have headaches or claudication when they run. When they rest, it goes away. Because many times we measure blood pressure only in the upper limbs. When you have high blood pressure in any child, please measure all the 4 limbs, the blood pressure. They'll have radiofemoral or delay, which you have is the differences between the upper and lower pulses. In an older child, we've talked about BP differences, and it might be mild or severe. So as the grow older, the left ventricle becomes more prominent. So you have a prominent impulse at the apex, you might have the thrill. And if they have bicuspid aortic valve, there will be an ejection click. There might be a continuous murmurs in the chest because of the collateral arteries that have developed. And we've talked about the PP differences and valve pulses. Treatment is supportive if they're in heart failure, manage the heart failure, manage the hypertension and any complications. Some of them will present with stroke. Some of you might have seen some of these children on the 7th floor with strokes as adolescents. Definitive management, usually we do catheterization and balloon, enlarged the coarctation, or we put a stent to support the vessel open. And if that doesn't work, we will then advise for surgical correction. When I say a stent, when we put a wire through the descending aorta to post the coarctation, then this is a mesh like that is collapsed, but when it's there, we open it up and we leave the coarctation narrow part wider now, and with something supporting so it doesn't collapse. The other obstructive lesion is valve stenosis. This could be at different levels, at just below the valve, at the valve level, or above the valve. Most times it will be at the valve level. So it could be, if it's on the left side, it could be aortic valve stenosis. This will cause reduced blood flow into the aorta. And because of that obstruction, the left ventricle has to pump against the resistance, so it will be hypertrophied and the heart enlarges. So what you will find is a murmur because of pushing blood through a narrowed part, thrill because of that murmur. The apex will be displaced because the left ventricle is hypertrophied. So these are things you will see on clinical examination. Just X-ray, you will have cardiomegaly. ECG, you will have left ventricular enlargement or hypertrophy. And then on echo, you will see what you will notice as the ventricular hypertrophy with obstruction of turbulent flow. If it's on the, and this murmur will be had on the aortic side, which is on the right upper sternal border. If it's pulmonary stenosis, the same things will happen, but now on the right side. So in this one, when you have right ventricular hypertrophy, the apex bit will be uplifted. You will still get the thrill. The murmur will be systolic because it's when blood is pumping through the aortic and pulmonary vessels and valves. But because the pulmonary valve is stenosed, the murmur will be across onto the left upper sternal border and less blood supply to the lungs. So it is right ventricular hypertrophy, which will be systolic murmur. And those are the things you'll find on examination and on ECG, and on echo will demonstrate the valve stenosis. The management, this is what we've said. The treatment is usually catheterization. We open up the valves through a balloon dilatation. Make sure that the balloon is narrow or flat. When it's across the valve, we blow it up with contrast and see how it's opening. So that is what we've talked about. Usually for aortic valves, if cath lab doesn't work, we will have surgery for repair, or if they're older children, replacement. I have taught you this before. When is it systolic? It is because either there is aortic valve or pulmonary valve stenosis, or there's a VSD, or there's a PDA. It means it's in systole. So if it is stenosis, it is where is the blood flowing through. So that's aortic pulmonary stenosis, or through a VSD, or through a PDA, because the pulmonary pressures are lower than the aortic pressures. The other alternative, which is in systole, the tricuspid and mitral valves are closed, but if they have regurgitation, then blood will flow backwards. So that is regurgitation of tricuspid or mitral would be systolic. Or across narrowed stenosed aortic or pulmonary valves, or across a VSD, which is shunt. It is diastolic if the valves that are open in diastole are narrowed, which is tricuspid or mitral valve. or if the valves that are closed are regurgitating. So this will be the closed valves in diastole is aortic and pulmonary valves. So if there is pulmonary regurgitation, aortic regurgitation, then it should be diastolic. The other alternative is in diastole, blood will flow from the aorta to the pulmonary artery if there is a PDA. So that would be what gives you diastolic murmur. So you recap and think it's a systolic murmur. What is happening? What would cause this murmur? If it is systole, what valves are closed? Which ones are open? If it is stenosis, which one should be affected? If it's regurgitation, which one should be affected? So that's how you tie up your clinical signs with what you see. So I will move to the cyanotic heart diseases quickly, and I will summarize this so that you don't get late for your next sessions. Reason for cyanosis is right to left shunting in the heart, right to left shunting in the lungs without necessarily getting oxygenation. But remember, there could be other causes of cyanosis like hemoglobinemia. So this is always think broadly. You have been told the five T's. TOF, which is transtrology of Fallot, transposition of great arteries. We'll talk about this briefly. Tricuspid atresia, truncus arteriosus, total anomalous pulmonary venous return, or TAPVR. Those are the 5 T's you've been told. For your level, I should add you that anything that stops blood flow to getting to the lungs will cause cyanosis. So if you have pulmonary atresia, if there's no pulmonary artery, that mixing will occur and you'll end up with cyanosis. What is most common of this is the trilogy of Fallot, which the tri means 4, and then Fallot is the person who described it. There is usually a VSD, usually large and restrictive. There is overriding aorta, so the VSD, the aorta overriding the VSD, and pulmonary stenosis. Because the VSD causes anterior displacement of the aorta, it causes obstruction of flow into the pulmonary artery. It might be at the infundibulum before the valve, sometimes it's at the valve, sometimes it's above the valves. Occasionally, you might even have small pulmonary arteries because of disuse. Then, because of this obstruction to flow into the right ventricle, and some of the blood flows into the aorta, the right side gets hypertrophied, and it gets worse as the child grows. And the obstruction to right ventricular outflow also worsens with age. So that is the 4 things that occur: VSD, overriding aorta, pulmonary right ventricular outflow tract obstruction, either pulmonary stenosis or below the pulmonary valve, and the subsequent right ventricular hypertrophy. The VSD is then restrictive, but in this way, the blood flows from the right ventricle to the left side into the aorta, and that's what causes cyanosis. Direction and magnitude of shunt depends on the severity of the obstruction. The more severe the obstruction, the more blood goes into the aorta, the more desaturated you will have, the more cyanosis you will have. And the obstruction to the through the RVOT is dynamic. Sometimes when the children are irritated, the heart pumps faster, and the obstruction gets worse. That's what we call with TET spells. There are few who have less obstruction, and they might not be a cyanose, but they are still tough. Newborns will present with murmur and cyanosis, and as they grow older, I've said the saturation decreases. As the clubbing develops, their cyanosis is variable, but it will be there. And they're the ones who will run for a short time and then squat. The squatting increases systemic circulation. And because the pressure in the systemic circulation gets higher by that squatting, there is slightly increased blood flow to the lungs, and therefore it reduces their symptomatology. That's why they squat. ECG findings will be right ventricular hypertrophy. You might have right axis deviation. Some of them are associated with the right bundle branch block even before repair, and most times after repair as well. Chest X-ray is a boot-shaped heart that you've been told about many times with reduced blood flow to the lungs. I've told you briefly about the TET spell, clinical presentation. They get hypercyanotic spell, acute onset with hypopnea due to the spasm of the infundibulum, right ventricular outflow tract obstruction. You would reduce pulmonary blood flow, they develop severe hypoxemia, and sometimes they might end up with altered consciousness and reduced level of consciousness. Very high mortality risk. Please calm them or let the mothers calm them. They're the ones who will give oxygen, have knee chest position, phenylephrine, and surgery if it doesn't work. Many times we'll also use a beta blocker. This is what happens. They cry, they become inconsolable, they become hypopneic, their cyanosis worsens. If you don't break this spell, you get unconscious and may die. So we need to break the spell and the distress. Chest X-ray, when you say boot shaped, this is where the leg gets in and the foot lies like that. So it's because of the pulmonary side becomes flat and becomes like a boot. The heart looks like a boot and the right atrial edge gets enlarged. So this is what we tell upturned apex is upturned, not as low as it normally is. The concave left upper sternal border where the left pulmonary artery is supposed to be, that also gives you a boot shape. Vascular markings might be reduced in the lung markings. Sometimes you have a right aortic arch. We've talked about this. Reduce agitation in TET spells, place child in chest, administer oxygen, give fluids, sedate to calm them. Beta blockers, propranolol, phenylephrine. If you have an ICU, send these children to ICU. They're the ones we should ideally operate as soon as possible. I've stayed more on TET spells and TOF because they are common causes of cyanosis in children, and we can do something about them in this country. Transposition of great arteries. Usually the pulmonary artery is from the right side and the aorta is from the left side. When you switch these two great arteries and the aorta comes from the right side while the pulmonary goes to the left side, so you end up with blood from the body into the right atrium, right ventricle, and into the abnormally positioned aorta back into the body without getting oxygenation. So that's why they are cyanosed. While the blood from the lungs comes to the left atrium, the left ventricle, and into the abnormally positioned pulmonary artery back to the lungs. So oxygenated blood from the lungs to the heart back to the lungs, while blood from the body goes to the heart and back to the aorta without mixing. If this is not rectified, the child will die. If there's no way of mixing blood so that a little of it gets oxygenated, these children will die. Sometimes they are complex. So what we need to do is look for emergency positions, look for a way of mixing the blood, either creating an ASD, which we call balloon atrial septostomy in cath lab. We will do one today. For those who will be cardiologists, you can come and see. Not more than 5. The alternative is to leave the PDA open so that blood mixes at that point. But the best mixing is at the creating an ASD. And then later, they will switch the aorta to go to the left side and the pulmonary artery to come to the right side, which we call atrial switch. This is best done within the first month of life. If you are somewhere out there, these are the children who will start asking you to start prostaglandin E, keeps the PDA open for ballooning. A balloon atrial septostomy is also called Rashkin procedure. Truncus arteriosus is the other T. It just means that instead of having 2 blood vessels coming from their heart, you have only one trunk coming from both ventricles, and then it splits into the aorta and pulmonary arteries. So because if there's no obstruction to blood flow into the lungs, the pressures in the lungs will be so high, we need to have these children repaired early. There is almost always a VSD, so that the blood from both ventricles goes through the single track. There might be different ways of how the pulmonary arteries come off the trunk. Many times it will be one, or you might have them coming from different sides. That's the more complex ones. Sorry, I said I'll tell you a little more. The reason they are cyanosed is that blood from the ventricles mixes in the trunk and then goes into the lungs. These are children who will have respiratory signs and symptoms of heart disease because they have a lot of blood flowing into the lungs. Since it's all going through one vessel, most of it will be directed to where there's less resistance, which is usually the lungs. If we don't do anything early, this increased pressure, increased volume into the lungs damages the lungs vasculature, and they end up with pulmonary hypertension, and we will not do anything about it. Early surgical correction is recommended in these children. Sometimes you end up with univentricular hearts or single ventricles, when many times if there's complete failure of septation of the ventricles, or if the tricuspid valve doesn't form, then you end up with an ASD and blood will flow through the mitral valve into the single ventricle. If there's no tricuspid valve, the right ventricle does not develop, usually it becomes rudimentary. Or if something happens with septation and the AV valves are deformed, sometimes you end up with that. So tricuspid atresia will be considered a single ventricle or univentricular in function. So what happens is that you have right atrial blood mixing with the left atrial blood and then into the single ventricle. Then you might have both great arteries arising from the single ventricle. So because of the single ventricle and oxygenated and deoxygenated blood mixing, that's why you end up with cyanosis. What we need to do is look for blood going to the lungs without going through the heart. In this way, the ventricle that is one will be left to pump blood to the systemic circulation. What we generally do early in this country is have the superior vena cava connected directly to the pulmonary artery. So blood coming from the upper part of the body goes to the lungs without necessarily passing through the heart. That's what we call a Glenn procedure, Glenn. And because in children, the upper part of the body is bigger compared to the lower, and there's more blood flow to the upper part of the body, so they can survive for a longer time. As they grow older, we will then convert the inferior vena cava, as well, to go directly into the pulmonary arteries if their pulmonary pressure is not high. And that is what we call Fontan, Fontan, Fontan procedure. So that then you have blood flowing passively into the lungs, but the single ventricle is left to pump blood to the systemic circulation after it has come back from the lungs. So that's what will happen in tricuspid atresia. The right ventricle is small, so you end up with blood flowing to the left atrium and into the left ventricle, and then either through a small VSDs into the pulmonary arteries, or the pulmonary artery will come from that single ventricle. Occasionally, you have hypoplastic left heart. It's also a single ventricle in physiology, where many times the left side does not develop well after the left atrium. So there has to be an ASD for this blood to flow into the right ventricle and then through the pulmonary artery. When the left ventricle doesn't form well, the ascending aorta is also defective, and the blood to the systemic circulation is dependent on our PDA. This is what I told you as hypoplastic left heart syndrome, duct-dependent lesions. Many times these ones will not survive, especially in this country. In other places, they try and fashion the left side so that the ascending aorta is connected to the right ventricle. In total anomalous pulmonary venous return, the other T of the 5 T's that you know is that you have blood from the lungs coming back to the heart without passing through the left atrium. So it forms some loop behind the left atrium, then is connected to the right atrium through some mechanisms. It can be through the superior vena cava, which we call supracardiac, most common, so that the pulmonary veins connect to the superior vena cava, then into the right atrium. or the pulmonary veins meet and join the coronary sinus, which then drains into the right atrium. Coronary sinus is the venous return from the heart. Then it goes to the right atrium and through an SD into the left atrium and left ventricle. Sometimes it forms that vessel and it somehow comes below the diaphragm and meets the inferior vena cava, which we call infradiaphragmatic, and then goes to the right atrium. Or you have a mix of all these. Some vessels drain into the superior vena cava, some vessels drain to the coronary sinus, maybe one or two will drain into the inferior vena cava, so where they are mixed. Because of the oxygenated blood, instead of going to the left atrium, directly goes through the right atrium, and then the mixed blood is what is pumped to the rest of the body. That's what causes cyanosis. If there are questions, kindly allow me to answer them when we meet in the wards because of time and you are late for your next session, unless they are burning questions. It's easy to diagnose children with murmurs, cyanosis, and clubbing as having cardiac disease. What we need you to focus is when we meet this, refer them for cardiac evaluation. For those that do not have a murmur, suspicion of congenital heart disease will be based from your history. The pointers will be an elevated heart rate, high or high normal. They might have tachypnea, even if they are very calm and happy and looking well. If they have tachycardia, tachypnea, please refer. Or any signs of respiratory distress with no fever. No signs of lung pneumonia or disease, but they are still having some element of respiratory distress. If they have reduced level of activity or they are breastfeeding poorly. And if they have poor weight gain with no reason for the poor weight gain, they are feeding well, their food is adequate, quantity, quality-wise, but they are still not gaining weight. Please refer them for further evaluation. There must be something wrong. So we've talked about the history and examination pointers. Those ones who have cyanosis is easy. If they have extreme fatigue, tiredness, or they usually get tired quickly, or they get out of breath. They have poor blood circulation, weak pulses, or pounding. I don't think it's pounding, it's supposed to be bounding. Sorry for that spelling mistake. Or they are excessively tired. So these are the suspicions of congenital heart disease. Even if there is no murmur, if you pick any of this, please refer them to us. And for those who came late, this was a summary of the lecture, that you have congenital heart disease split into those that do not have cyanosis and those that have cyanosis. So for those that have no cyanosis, it might be due to the volume load, where you have increased blood flow from left to right shunts at the ASD, VSD, PDA, or AV canal, which is a combination of ASDs and VSDs. Or it is because of pressure load, which might be due to obstruction to ventricular outflow from the right, which causes pulmonary valve. And the left is aortic valve stenosis or coarctation of the aorta. And for those that have cyanosis, there could be increased blood flow because of the reduced pulmonary pressure, so you have increased blood flow to the lungs, but you have mixing of the blood or no saturation at all taking place. So that will be transposition of great vessels, single ventricle physiology, truncus arteriosus, TAPVR without obstruction. Or when there's obstruction, to flow into the lungs so that blood bypasses going through the lungs and mixes with the rest is the circulation. When it's tough, most commonly tricuspid atresia or severe pulmonary atresia. So those are the summary. I will end there. Sorry for my sore throat. Lavinda, we will ask them to ask questions later in class. Thank you. Or in the ward rounds. Go ahead, Lavinda. Go ahead, Dr. Lavinda. Did you get anything? It was too fast.
It wasn't too fast.
Pardon?